Pain Theory and Perception by Liz and Anissa. Okay, so pain, as we all know, is a protective response. It's the body's way of informing you that something is wrong or that there may be some tissue damage. Pain is also a multidimensional experience, and many of the patients treated by occupational therapists report pain as one of the components which may limit their ability to actively participate in their occupational therapy roles or tasks. So we all view pain differently. So our perception of pain is usually described with words and phrases which are utilized by the occupational therapist by determining the type of pain and its emotional impact on that individual. The primary classifications of pain are acute and chronic. Chronic pain is a poorly localized pain with the underlying cause not being fully understood or clear to the patient or clinician. It is a reoccurring pain, and it reoccurs at interval and it persists, either way. It is long of duration, and some examples of chronic pain include low back pain and arthritis pain. With acute pain, it occurs with rapid sudden onset and is considered warning signal by the body that tissue damage of injury is about to occur or has already occurred. It lasts from seconds to days. Some examples of acute pain include cuts, bruises, broken bones, and burns. Some other types of pain that are not primary include referred pain and persistent pain. Referred pain is a pain felt at a site different from the original source of injury or disease, and a persistent pain is a pain which continues for long periods of time or it is consistently recurrent. There are several sources of pain. The first one is the peripheral neurogenic pain. The peripheral neurogenic pain is caused by the involvement of the neural tissues resulting in mechanical and psychological changes in the body. Peripheral nociceptive pain is accompanied by the inflammation secondary to the release of chemical mediators such as prostaglandins, histamines, and bradykinin.
Pain is a protective response and is the body's way of informing an individual of potential tissue damage. The body responds to trauma through a series of reactions associated with the autonomic nervous system or the fight or flight response. Nociceptors are sensory receptors specific to pain located in the skin, viscera, cardiac, and skeletal muscle that receive and transmit painful stimuli. Nociceptors may also be affected by the release of pain-producing substances into the tissue such as potassium, serotonin, bradykinin, histamine, prostaglandins, and substance P. They are sensitive and responsive to mechanical distortion, variations in chemical components in the tissue fluid, and by thermal changes. These specialized receptors possess variable thresholds, some high and some low. Peripheral nerves receive a nauseous stimulus, then an afferent cue is set particularly through small nerve fibers to determine the intensity of the pain. Then a pain threshold is reached, which causes neurotransmitters to be released. Then an electrical impulse travels through the spinal cord through the dorsal horn, which then enters the brain, where it is first received by the reticular formation. Then the thalamus interprets the signal as pain, then sends a message to the limbic system, where emotional awareness is generated. Impulses are then sent to the somatosensory cortex, which evaluates the nature of the pain, and lastly, information is sent to the frontal cortex, where emotional and physical responses are organized and carried out.
The view of pain is described in the next three pain theories.
The majority of the perspectives include psychological factors of affective behavioral, cognitive, situational, and sensory physical. Theoretical perspectives on chronic pain have been categorized as restrictive, which include mind-body dualism, psychological, radical operant behavioral, and radical cognitive, and comprehensive, which is based on the International Association of the Study of Pain, which is categorized as gait control, non-radical operant behavioral, and cognitive behavioral.
So the neural matrix theory, it supports that pain is produced by the output of a widely distributed neural network of the brain rather than the sensory input evoked by injury, inflammation, or pathophysiology. Output patterns of the body's self neural matrix initiates perceptual, homeostatic, and behavioral responses after an injury, pathology, or a chronic stress.
Pain is usually believed to be related to the amount of tissue damage, but during World War I, physicians noted that some soldiers who were terribly disfigured had minimal tissue damage. This concept led to the gait theory of pain. Peripheral stimuli occurs in the dorsal horn of the spinal cord, which acts as a gate to the varying amounts of input from the large A fibers that close the gate and small C fibers that open the gate. This theory was impetus to the advancement of the use of electrical stimulation of sensory fibers to effectively decrease pain in individuals. Advances in imaging and neuroscience led other researchers to explore the influence of pain-mediating chemicals produced by the body known as endogenous opioids that affect both the central nervous system and peripheral nervous system through the interaction of specific chemoreceptors and pain-mediating substances. The three forms of opioids are enkephalins, dynorphins, and beta-endorphins. Each have a pain chemoreceptor binding site on the neurons. Enkephalins are located in the dorsal horn and are released by spinal interneurons. Dynorphins are found in the central nervous system and are released by dense corpuscles, and beta-endorphins are located in the hypothalamus and they're released by stress. Pain perception is a reaction based on anatomical, physiological, chemical, and psychological factors. These factors led to the development of a biopsychosocial approach for the conceptualization and treatment of persistent pain. In this approach, pain is viewed as a complex experience affected by sensory input, but also influenced and related to behavioral, cognitive, affective, and environmental factors. All of those factors can influence and be influenced by changes in a set of variables such as pain-related, perceived social support, pain beliefs, and pain coping. To effectively treat a patient with persistent pain, the therapist must recognize the influence and interactions of the factors underlying the biopsychosocial approach and develop strategies and interventions related to each area. The patient also needs to be viewed holistically within their occupational context.
So you may be wondering, what is the purpose of learning about the pain theories? So the purpose of learning about this is because we need to know what our patients are feeling. So pain is experience rather than a bodily function, and it must be placed within the greater contextual picture. So being aware of our patients' psychological and mental factors can help us identify and understand an accurate diagnosis, which will help us assist in refining the appropriate treatment intervention. So for example, what I mean by that is if a patient with migraine headaches may report that it's due to stress or menstrual cycling, that could help us understand the kind of pain the patient is feeling and how to address any type of treatment we would be doing with this patient. How do we as OT practitioners assess pain? Here are our assessments. Although the pain theory and perception is not a physical agent modality, it could have a certain procedure that it utilizes to assess pain. The procedure involves the patient going through a thorough history evaluation assessment. That includes knowing how they describe the pain, how the pain was developed, the location of the pain and whether it has spread, the pattern of the pain over time, the patient's level of function and impairment, and the previous attempted treatments, and the patient's impression about the effectiveness of previous treatments. As we have seen in our pathophysiology class, the McGill Pain Questionnaire is utilized during the initial evaluation. This questionnaire consists of 3 parts, And in those 3 parts, you're asked, what does your pain feel like? How does your pain change with time? And how strong is your pain? There's also a pain rating index, which is a standardized list of adjectives in which the patient selects what best word describes the pain. The body diagram is there to assist in identifying and locating their pain. And it also helps with identifying if the pain is internal, external, or both. So the visual analog scale is also another scale we've already seen before. This one provides clinicians with a quick and relatively accurate method for patients to rate their pain. It is a 10 centimeter line marked on a paper. On the left it has no pain, and on the right it has pain as bad as it could be. And there's also the Wong-Baker Faces Pain Rating Scale. This one's used for children. It has the cartoon-like faces in various degrees in which the child chooses which one presents their pain. 0 is also no pain, and then 10 is worst pain level ever. Thank you for watching.